A very good day, my dear postgraduate students. Welcome to SNIP, Short Notes in Pathology. The topic for the day is stellate radial scar. I would advise you people to kindly get acquainted with the topics. If you know the question, you know 50% of the answer. There are other terms for this, and you should be familiar with all. The radial scar, radial lesion, radial tumor, stellate cell tumor, stellate cell, stellate reticulum, and sclerosing carcinoma. So these are all various terminologies. Sometimes they can be used in a jumbled fashion. Just be aware of them. And these are some important organs, the breast and the kidney, from which I had taken the lesions. But please do remember that there are other organs such as liver, pancreas, etc., where you can get stellate lesions. Time may heal all wounds, but it does not erase the scars. A beautiful quote from Jane Gallen. What is the significance of this? The Greek word desmos, all of you know, desmoplasia, etc. It is a knot or round, and plasia means proliferation. Thanks to Wikipedia. The clinical as well as the histological mimics for the sclerosing lesions ranges from adenosis to infiltrating tumors. Many a time, the surgeon had diagnosed it as a malignancy, and before the recent years, even mastectomies have been done. So, the clinical picture should be borne in mind. And there can also be a transition from an adenosis to a hyperplasia to an atypia, and eventually there can be a subsequent carcinoma also. So this sequence of events we should remember and alert the clinician and reassure the patient, who should again visit the doctor to rule out a malignancy in future. Look at this beautiful picture, courtesy the author over here, Science Photo Laboratory. I'm finding the broad eosinophilic bands that are virtually entrapping the hyperchromatic cells. So we can use the word literally entrapment. Small groups or even individual cells are surrounded by bundles of collagen, such as the sclerosing suffocation. Definition. It is a benign breast lesion with a central fibroelastic core and radiating ducts and lobules. A beautiful definition. Look at this one. I'm finding that something is confluent over here from which there are radiations, and then there is the fatty tissue that is supporting it through. In some areas, there are some cystic dilatations also. So the terminology can be radial sclerosing lesion or complex sclerosing lesion, usually more than 1 centimeter in diameter. So that will be the basis for the pathological and the radiological diagnosis. So it is a benign breast lesion with a central fibroelastic core. Look at this over here. So this is the core from which I am finding multiple radiating channels or lesions. And some of which, look at this minute spaces, are showing cystic lesions as well. These three components you must remember. And there can be mimics such as an invasive carcinoma, atypical breast. These are the essential features. It is a benign breast lesion with a central fibroelastic core. Look at this region over here, from which there can be radiating lobules. And they can be having, look at this minute spaces, cystic changes. So it resembles a stellate scar in which the epithelial elements are being entrapped. And it can mimic an invasive carcinoma. And sometimes you find in this stellate scar itself, there can be atypia or malignancy might subsequently arise. And the treatment will be observation, clinical, and radiological follow-up. Grossly, it mimics a carcinoma. All of you would have heard of the term the stellate carcinoma, wherein there is a puckering of the skin, there can be indrawing of the nipple, etc. And it can even be fixed to the underlying pectoral muscles. Here, again, I am finding a lesion with a stellate configuration, and this is a normal parenchyma with the fat. It can appear pseudo-infiltrated. Normally, you find that there is a kind of a grayish and a firm tinge in a fibrous tissue, whereas in a case of a carcinoma, there will be softening that can be helping us to differentiate it. So fibroelastic core and fibro and epithelial or myoepithelial cells resembling a carcinoma. Beautiful picture. The age is around 40 to 60 years. There again is a paradox. So almost the same age. But the catch for us is it is multicentric. It can be bilateral. No tumor can be bilateral, multicentric, and the patient be walking into you comfortably. Sometimes a clinical judgment matters. So there is no history of trauma or surgery either. And it is a misnomer that it is infiltrating. The synonym can be a radial scar, complex sclerosing lesion, infiltrating epitheliosis. So I'm quite slow in my class. It does not matter how slowly you go, as long as you do not stop. I have not stopped. I have completed more than 1,000 classes. Stoic wisdom, something I like. The clinical features. It can be incidental, it can be palpable. Usually it is diagnosed by the patient herself. And radiologically, the ultrasound, mammogram, MRI, they come in very handy. Also, a core needle biopsy is done, but it is better to avoid because the fibrous tissue, particularly with an entrapped gland, can be a little more delicate and confusing. Excision biopsy is preferred. FNAC is not diagnostic, it can appear acellular. So clinically what I had mentioned, firm nodules diagnosed by the patient, history of pain on and off according to the menstrual cycle, bilateral, multifocal and premenstrual. Radiology, there is an architectural distortion. Here again I am finding a dip from which there are needle-like extensions through. A puckering is also made out. Similar radiolucent lines. Spiculated, which means sharp and spiky. That is what I am seeing. The differential diagnosis we have already mentioned, invasive carcinoma. Also microcalcifications can be present. Hypoechoic mass in the ultrasound. Microscopy. Again, the broad bands of fibroelastic stroma with the entrapped glands that I am seeing through. There can be distended glands or ducts which are made up. Look at this one over here. Secretions might be present and inflammation is definitely sparse. So it is not an inflammatory lesion. And touch wood, there is no pleomorphism. So these are all the microscopic features. Please have them in mind. And look at this. There is a zonal architecture. It is grossly asymmetrical, a very beautiful finding. I had taken it from the learned pathology. Look at this over here. I find that there is an asymmetry between this region and this region. Zonal architecture. There is a central region and then there is a peripheral, relatively confluent areas and then more detached areas towards the periphery. So this gives a targetoid appearance as though it is a bullet proof. An atypical hyperplasia, invasive carcinoma to be ruled out. And we are supposed to look for the epithelial as well as the myoepithelial cells. And sometimes there can be a florid hyperplasia. So microscopic appearance, as I mentioned earlier, stellate, fibrosis and elastosis, radiating lobules and ducts. Sometimes there can be obliteration. Background is somewhat sclerosing and there can be adenosis. Apocrine changes can be present. We had mentioned all this. And in complex sclerosing lesion, it can be more than 1 centimeter. Let us a little more complex over here and it can be bewildering. So low power is always best. You look at the radial scars as such, in which there are entrapped glands. Thanks to pathology outlines for this beautiful details and picture. By heart these. The other features we have already mentioned. One is an invasive ductal carcinoma. Yet another one can be a tubular carcinoma, which can be subareolar, and there will be a confluence over there. Low-grade adenosquamous carcinoma can be there because of the metaplasia. And the positive stains are, look for the myoepithelial stains, P63CD10, the smooth muscle myosin, heavy chain, and the smooth muscle actin. These will help us in the diagnosis. And always I find my students moving fast forward. Moving fast is not the goal. Moving correctly is. Please have this in mind. The next lesion is the oncocytoma. The renal oncocytoma is a benign lesion again. Here again I am finding a stellate lesion. This is oncocytic. It has got a mahogany brown-like color. And the radial spikes can be made out. Sometimes you find that there can be eosinophilic cells. We'll see the details later on. But this one, well circumscribed, and I find that there are the COTs. These are the markers. This is for you to leisurely go through and find out what is positive in the case of chromophobe RCC, clear cell RCC, and oncocytoma, a translocation in an RCC, and then a papillary carcinoma, etc. Kindly go through this entire one, and thanks to this particular reference. It is a benign renal epithelial lesion characterized by large eosinophilic cells which are packed with mitochondria. This is a little important. The essential features are it is benign and oncocytic. Oncocytoma means the cells will be somewhat liver-like in contour. Chromophobe carcinoma can be a differential diagnosis, so also renal cell carcinoma. So this is a gross picture. It is a well circumscribed lesion that has of course been cut open. Therefore, I am finding a mahogany brown lesion as such with a stellate punctate lesion. That will be showing some kind of a radiation which I can make out in the form of these darker lines. And they can extend and expand into the perinephric fat, sinus fat, or even the renal vein. So hemorrhage can be present, but there is no necrosis. So this is showing some kind of a distension, probably a hydronephrosis is also there. Microscopically well circumscribed, already seen, no pseudocapsule, and it abuts the normal parenchyma. There are solidness. Look at these liver-like cells which are having abundant eosinophilic cytoplasm and central nucleus. There is no papillary architecture. The oncocytes are seen, they have got a granular cytoplasm, and the chromatin is evenly distributed. Sometimes small nucleoli can be seen. Bizarre cells can be there due to degenerative changes. It is homogeneous. Sometimes there can be necrosis because the mass outgrows the blood supply. Hence a scar can occur. Look at this one, again the radiating scars. This is where radiology comes in handy. It goes hand in hand with pathology nowadays. Origin is from the renal intercalated cells packed with mitochondria. Additional P53 mutations can be present. This is an electron microscopic picture in which I am finding the numerous organelles. And one of the mimicker will be the renal cell carcinoma. These are all the mitochondria, that is why it is appearing granular. The take-home messages are benign lesion, well recognized radiologically and a pathological entity. Postmortem studies have shown that these are quite common, but benign and associated with benign breast disease in the case of breast, and so also in the kidney. The screening programs show that there can be ATPR malignancy. This is for the breast. And in view of the association, excision biopsy should be done and not a needle biopsy. So, oncocytoma and renal cell carcinoma can be similar. So these are all the references. I would like you people to kindly go through it. And so are the references for the renal oncocytoma or the stellate scar of the renals. So kindly go through it. It is an important university question, difficult to answer. Thank you.